These are answers to case number 6 involving 32-year-old female G1P0 and with recent diagnosis of gestational diabetes, who presents at the OB clinic at the gestational age of 32 weeks and with a chief complaint of persistent headache. Per patient's report, she's been having progressively worsening peripheral edema, and her blood pressures have been in the 140s and 150s. But further workup showed that her blood pressures were elevated to 160 over 110. Urine dipstick showed 1+. Proteinuria, protein to creatinine ratio was 0.3. Her platelet count is decreased. Her platelet count is 100. So the questions were, what is happening to this patient, or what's the most likely diagnosis? What's the recommended treatment? What are the complications of this condition or feared complications? How do you prevent this condition? Would you deliver this patient? And depending on the gestational age, if you decided to deliver this patient, what sorts of treatments are needed? And what are the risk factors, and what's the prevention? So based on her gestational age of 32 weeks after 20 weeks, and proteinuria and elevated blood pressures and other symptoms such as persistent headache, this patient is having preeclampsia with severe features. So what is preeclampsia? So preeclampsia is defined as a new onset of elevated blood pressure and proteinuria after 20 weeks of gestation. As far as pathophysiology is concerned, the exact cause remains to be unclear, but many theories center on abnormality with placental implantation. And one of the common findings or physiological changes associated with this condition is intense systemic vasospasm and decreased perfusion to vital organs. It's an inflammatory process, basically inflammatory process affecting endothelial cells or blood vessels and leading to decreased perfusion to vital organs. You can imagine blood vessels, endothelial system or the vascular system is affected, and your body tries to repair this endothelial injury using the coagulation system. So one of the complications of preeclampsia is you can have a DIC or disseminated intravascular coagulation, where your body tries to repair these micro injuries, and in the process, because of the injuries, you lose fluid. So there's third spacing leading to peripheral edema. When you lose fluid, you concentrate blood, so it leads to hemoconcentration, and that's decreased blood flow to vital organs, leading to injury. For example, kidney injury, liver injury, or other organs. So decreased perfusion, hemoconcentration, third spacing, and so for diagnostic criteria, you need elevated blood pressures and elevated protein in urine or proteinuria. So blood pressure 140 over 90 increase from baseline, plus proteinuria 0.3 grams or more in 24-hour urine, or on a urine dipstick 1+ or more. Severe preeclampsia, on the other hand, would include blood pressures elevated to 160 over 100 or more. So this is elevated blood pressures elevated to 160 over 110 on two separate occasions, at least 6 hours apart in a patient at rest, plus proteinuria, significant proteinuria, 5 grams or more of protein in 24-hour urine, or 3 plus or more on urine dipstick. And other symptoms or features of preeclampsia with severe features include visual symptoms, cerebral or visual symptoms like blurry vision, other neurological symptoms, pulmonary or respiratory symptoms, abdominal symptoms, right upper quadrant pain, elevated liver enzymes, decreased platelet count as in this patient, and evidence of intrauterine growth restriction or IUGR. So preeclampsia is considered hypertensive disorder of pregnancy, and depending on when this disorder happens, you can classify different hypertensive disorders. If it is before 20 weeks, and if it is just elevated blood pressures without proteinuria, it's considered as chronic hypertension. But if it is before 20 weeks and with elevated blood pressures and elevated proteins in urine, plus other evidence of end organ damage, you can still have preeclampsia superimposed on chronic hypertension, even before 20 weeks. But if you develop elevated blood pressures after 20 weeks without proteinuria, it's considered as gestational hypertension. But if you develop hypertension plus proteinuria plus other symptoms, this is considered as preeclampsia. If there are more alarming symptoms, like in this patient, blood pressure is elevated to 160 over 110, evidence of end organ damage, whether it's kidney or liver or the brain, that's considered as preeclampsia with severe features. So depending on if the symptoms are before 20 weeks, before the symptoms are before the gestational age of 20 weeks, or after, you can classify hypertensive disorders of pregnancy into different categories. So the other question is, what are the risk factors? So the risk factors for preeclampsia include any medical condition that with the potential to cause microvascular disease, whether it is diabetes, hypertension, any vascular or connective tissue disorders, antiphospholipid, antibody syndrome, nephropathy, and so forth. And anything that involves the pregnancy itself, whether there are chromosomal abnormalities, abnormal pregnancies like mole pregnancies, hydrops fetalis, multifetal pregnancy, if this is egg donation or donor insemination, structural congenital anomalies. These are pregnancy-associated factors. There are also some maternal-specific factors that are attributed as risk factors. These are age greater than 35 or age less than 20 years. And also being of a specific race, black race, previous history of preeclampsia, family history of preeclampsia, nulliparity or first pregnancy, other medical conditions, any medical condition that affects blood vessels, any form of diabetes, diabetes type 1, gestational diabetes, obesity, renal disease, stress. These are all attributed as risk factors for preeclampsia. Possible paternal specific factors include first-time father, previously fathered a pre-eclamptic pregnancy in another woman, So these are possible factors. As far as clinical presentation, patients can have insidious or fulminant presentations. They can have mild symptoms, can have elevated blood pressures and proteinuria without knowing that they have preeclampsia, or you can have severe symptoms, such as persistent headache, right upper quadrant pain, abdominal pain, difficulty breathing, and so forth, plus significant proteinuria, elevated blood pressures, and abnormal labs. And as far as complications of preeclampsia or hypertensive disorders, preeclampsia increases the risk of placental abruption, cardiovascular complications, whether it's heart problem, whether it's heart attack, stroke, acute renal failure, disseminated intravascular coagulation, maternal death, and those are all possible complications. Other feared complications of preeclampsia include HELLP syndrome, where there is hemolysis of red blood cells, elevated liver enzymes, and decreased platelet count, leading to other problems. And the other feared complication is eclampsia, where seizure happens during pregnancy. So as far as diagnostic evaluation, as part of initial prenatal assessment, pregnant women should be questioned about potential risks of preeclampsia. We should have complete obstetric history, specifically history of hypertension or previous preeclampsia. We should have a thorough medical history. We need to know if this patient has history of diabetes, hypertension, any vascular or connective tissue disorder that affects blood vessels, if there's any history of antiphospholipid syndrome. And before or after 20 weeks of gestation, we should always ask for symptoms, those symptoms that would be consistent with preeclampsia, those symptoms such as blurry vision, persistent headaches, epigastric or right upper quadrant pain, and increased edema. Concerning edema would be like facial edema, rapid weight gain, and those sort of things. So during physical exam, we should always check blood pressure, and patient should be in a rested position when doing blood pressure. We should always measure the fundal height at each OB visit, just to make sure that size matches with gestational age. If size is less than the dated gestational age, it might show it could be the evidence for intrauterine growth restriction, or IUGR. As far as studies goes, in addition to doing the lab workup, including CBC, CMP, to check for liver function, kidney function, and so forth. If patient is diagnosed with preeclampsia, we should do ultrasound, NST, and also BPP when indicated. So as far as treatment, the definitive treatment is delivery. And as far as the indications for delivery in preeclampsia, there are fetal indications and maternal indications. Fetal indications include severe intrauterine growth restriction, so baby's not growing as expected. There is non-reassuring fetal surveillance, whether when you are doing an NST or biophysical profile. If there is oligohydramnios, and maternal indications include gestational age of 38 weeks or greater, platelet count less than 100,000, and worsening of renal function, hepatic function, suspected placental abruption, persistent symptoms such as persistent headache or visual changes, severe epigastric pain, nausea and vomiting, and of course if there's eclampsia. As far as transfusion, according to some sources, if C-section is being considered and platelet count is less than 50, patients should be transfused with platelets. Otherwise, if it is vaginal delivery and if platelet count is less than 20,000, transfusion should be considered. As far as treatment is concerned, depending on if patient has pre-eclampsia with severe features, if there's a possibility of pre-eclampsia with severe features progressing into eclampsia, patient needs to have a seizure prophylaxis with magnesium sulfate. Commonly used regimen is 6 grams of loading dose of magnesium sulfate, followed by continuous 2 grams per hour infusion. And as far as blood pressure control is concerned, systolic blood pressure 160 to 180 and diastolic blood pressure 105 to 110 or higher should be treated. And the goal of the treatment is to keep the blood pressure less than 140 or 150 systolic, and then diastolic less than between 90 and 105. Dosing for hydralazine is 5 milligrams IV or 10 milligrams IM given, and then patient's blood pressure is monitored. If blood pressure is controlled, hydralazine can be given every 3 hours until maximum dose of 400 milligrams per day is given. But if blood pressure is not controlled, the same regimen can be repeated. IV hydralazine, 5 milligrams or 10 milligrams IM every 20 minutes until blood pressure is controlled or until maximum daily dosage is reached. And if blood pressure is not controlled with this medication, alternative antihypertensives should be considered. And the dosing for labetalol is 20 milligrams IV bolus. And if blood pressure is not controlled, give 40 milligrams IV 10 minutes after the initial dose. Then 80 milligrams every 10 minutes for 2 doses until a maximum dose of 220 is reached. And if you don't have access to IV medications, nifedipine is another oral antihypertensive that can be used. So in women with preeclampsia, blood pressure should normalize immediately after delivery, but it may remain elevated for 2 to 4 weeks. But if blood pressure remains elevated for 2 weeks, that would be a diagnosis of chronic hypertension. As far as prevention is concerned, currently there is no well-established measures for preventing preeclampsia, but some evidence support that the use of low-dose aspirin therapy and daily calcium supplementation in certain high-risk women has shown some benefits. But there is no established dosage for calcium. Low-dose aspirin, 100 milligrams or less, has been shown to reduce the incidence of preeclampsia. Again, as far as prevention is concerned, early detection, careful monitoring, and treatment of preeclampsia is crucial in preventing mortality related to this disorder. Although preeclampsia is not preventable, many deaths from this disorder can be prevented, and women who do not receive prenatal care are 7 times more likely to die from complications related to eclampsia than women who receive some level of prenatal care. So early detection, addressing the risk factors, and treating those symptoms, elevated blood pressures, and prophylactic treatment while patient is undergoing this condition is very important. And one last additional point is, depending on the age of delivery, whether it is before 32 weeks or 34 weeks, giving corticosteroids for lung maturity is beneficial and is found to decrease respiratory complications down the road.